today we're going to have Dr. Medina speak to us about breast cancer screening. Dr. Medina comes to us out of the Dookie area. That's a different color of blue than I enjoy, but it's okay. A little lighter, a little more west would be fine with me, and I'm not talking about sky blue. And if they have a football or basketball team at UNC after the next 10 years, I'll be surprised. She also then went to Miami and spent quite a bit of time in radiology there, but came from the hot part of Miami to temperate East Tennessee in 2006 and has been on staff since that time. I have read many of her mammograms that she has done for my patients and have been quite pleased. So, Dr. Medina.
Thank you. So I am going to talk to you about breast cancer screening and also, not just breast cancer screening, but to try to get you to understand that breast cancer actually is a pretty heterogeneous disease. It's part of the reason why there's so much confusion about whether we're over-aggressive or underly aggressive with treating women. And some of that confusion is just because the disease is heterogeneous. Breast cancer is not the same for every woman. And I want to also talk a lot about how screening really needs to be tailored for the woman based on her lifestyle, her risk factors, and all of those things. That's a kind of new concept that you might have heard of called precision medicine, where we're going to start to not just do one-size-fits-all medicine for patients anymore. We're going to try to tailor it to each patient. And, just some basics. We'll talk about just some basics of breast cancer and breast cancer screening, in case you don't know, which you probably do already. So just, you've probably all seen these statistics. Every woman has about a 1 in 8 chance of getting breast cancer in her lifetime, okay? And that's all comers. And then every year there's about a little more than 225,000 cases diagnosed in women and about more than 2,000 in men. And then of those, 40,000 deaths we see from breast cancer a year versus 400 deaths in men every year. But you can at least see from this that, most of the time breast cancer is not a fatal disease. And of course, where breast cancer arises is actually in a structure called the terminal ductal lobular unit. So the breast has, is composed of these terminal ductal lobular units. And they are, composed of the lobules, the glands, the milk glands, and those are connected to the ducts that would carry the milk to the nipple in somebody who was lactating. And so that is where the breast cancer actually begins. And you can have two basic types of breast cancer. One can be an invasive ductal breast cancer, and those are cancers that end up predominantly involving, the ducts. And then there's the invasive lobular carcinoma, which tend to be a little bit more centered in the actual lobule. Those two types of cancers are mainly important to distinguish because they do behave slightly differently. But otherwise, there are many similarities in the way that they're treated and the way that they're staged. So remembering that breast cancer, if you catch it before it's become invasive, the thought is it probably starts with abnormal cells that are confined in the duct or in the lobule. So what we see this the way that we are able to see this on mammography is typically with the presence of calcifications. So, and that's one way that early breast cancer or ductal carcinoma in situ can manifest. So if we're able to see ductal carcinoma in situ, which is just where abnormal cancer cells are confined within the duct, then we generally will see them as calcium deposits on the mammogram. And in this case, you can see these tiny little white dots, and you can't even really resolve them all, honestly, on these. We even use magnifying glasses to see them, and we're using very high-resolution images and high-resolution monitors. And if you were to do a biopsy of this is what you would see. You would see that there are abnormal cells, and they're all within the duct. None of them invade through the duct wall. And contrast that to an invasive cancer, which usually presents on a mammogram or ultrasound as a mass. And in here, this is just a small mass. Generally, when we look at masses, we try to talk about the margins of them. If they're smooth all the way around, that's more likely to be benign. If they're spiculated, that's more likely to be malignant. And some other things we look at are the shape. So round is usually more predictive in a solid mass of breast cancer, whereas oval is more associated with a benign kind of mass. So this is a small little cancer in this breast, and if you were to do a biopsy of that, you would just see cells, streaming through the tissue. These are the fatty cells, and there's nothing really confining these things here. They're just kind of beginning to stream through the tissue, and once they're there, they'll have, access to lymph nodes and lymph ducts, and be able to eventually spread throughout the rest of the body if they're able to. So that's just a little bit about breast cancer and the types of breast cancer. We'll get a little bit more into the subtypes of breast cancer later on. But the thing I do want to have you understand about the way we screen women, a lot of that will have to do with their risk, okay? So when we talk about breast cancer risk, we try to basically categorize women's risk levels in 3 or 4 categories. So there's first the risk that most women have, which is the general population risk, and those are women that are have a risk of up to 15% in their lifetime, and then those women also do have any woman has about a 1% chance of ovarian cancer, and these women minor risk factors play a greater role, things like obesity, smoking, alcohol use. And so those become, in those women, those would be the risk factors that you would focus on as far as preventing breast cancer, okay? Then the next category and the next level up as far as the risk is the familial category. So women with familial level risk have a risk of up to 40% of breast cancer and 11% of ovarian cancer. And in those patients, obviously you can't modify their familial risk factors, but you would concentrate on those risk factors that you could modify, and you would also probably screen them differently, okay? And then there are a small subset of women who have had biopsies before and have had high-risk lesions identified in the breast. Atypical ductal hyperplasia or lobular carcinoma in situ are both findings that will predict a much higher risk of the woman's later developing breast cancer. And the risk level in those women is up to 65%. And generally, anymore, those women, we advise chemoprevention in them, and also higher level of screening. And then finally, the highest level of risk is in those women with hereditary breast cancer syndromes. And there are a few of those syndromes that do have breast cancer as one of the components. The one that you're most familiar with is the BRCA1 and BRCA2 gene, but there are many genes that have, that run in families that are associated with increased risk of breast cancer, among other cancers. And remember, too, it's not just breast cancer in women with BRCA, it's also pancreatic cancer they have a higher risk of, and men prostate cancer. So even though it's a BRCA gene, be aware that they are also at risk for other types of cancer by having that. So as I was kind of alluding to, we will screen or treat these women based on their risk level. So an average risk woman is going to get a clinical breast exam every year. She's going to get a yearly screening mammogram beginning at age 40. And you're going to be looking at those, lifestyle risk factors, obesity, smoking, alcohol use, as far as breast cancer prevention. A woman with a familial level risk, if she has a risk of greater than 20 to 25% lifetime risk, then in addition to the mammogram every year, you're going to do an MRI every year. And you're going to pay attention to when you start the mammogram. And these women, you would start at 10 years prior to the youngest affected relative, but not sooner than age 30, okay? And then in the next level, in the high risk patients, the atypical ductal hyperplasia or lobular carcinoma in situ, you would do mammography, also MRI every year, and you would consider chemoprevention with tamoxifen or something similar, okay? And in the hereditary level risk level, we're talking about a much more aggressive intervention here. We're talking about oophorectomy by age 40. We're talking about prophylactic mastectomies. And we're talking about these, women that qualify are definitely genetically tested so that like anybody who has this really strong family history and that has certain predicting factors, you test them so that you know that they're in this risk category. We talk about chemoprevention or even the use of birth control pills. And then, of course, if they do keep their breasts, mammography and MRI, starting the mammogram at age 30 and MRI at age 25. And there is some literature beginning to talk about using CA-125 levels as a screening tool, but there's not really good data on that for these women yet. So if we're talking about this high-risk group and what we're going to do to prevent their breast cancer, if we do prophylactic mastectomy, that comes with it a 90% reduction in their risk of getting breast cancer. And even more important than that is the oophorectomy, probably, because it will decrease their risk of of ovarian cancer 90%, but it also decreases their risk of breast cancer by 50%, just the oophorectomy. And again, selective estrogen receptor modulators or aromatase inhibitors, these give an additional risk reduction benefit. And especially you want to give these to patients in this 40 to 60-year-old age range. And then, you may also be able to intervene with smoking cessation, weight loss. And again, that weight loss is very important. I can tell you, in the risk models that we use, obesity really increases their risk. So that's a real thing, okay? And we have a lot of obese women. So that's, that's the high risk group. But in most women, we're going to use, routine cancer screening, and the mainstay of breast cancer screening, of course, is mammography. So mammography is the only modality that has been actually shown to reduce the number of deaths from breast cancer. Now, that doesn't mean that if we did the studies, we wouldn't find that MRI reduces them, but there just isn't that data yet available. We predict that probably MRI will have an impact on mortality, but to date, this is the only modality that we know will save lives, for sure, that we know that. And mammography is very harmless. It's a yearly dose of about 0.4 millisieverts, and to put that in perspective, the amount we get from the environment is about 3 millisieverts a year. And the risk of getting cancer from a mammogram in excess of your 1 in 5 risk of getting cancer in your life, because you're human, is an additional 1 in 100,000. So it's very low. If your patients have concerns about that, I think you can put their concerns at ease, okay? But mammography is great about those things, but the problem is that it's not 100% sensitive for detection of breast cancer. So as a screening tool, it's really not ideal. Overall sensitivities are probably in the range of 70 to 80%. Okay, so we're going to miss 30% of breast cancers with it, possibly. It does have good specificity. And in some studies where they're looking at high-risk patients, the sensitivities can be as low as 25 to 30% or even lower in some studies. And that's really not enough, okay? It's really not enough. And that's why you're seeing a lot of emphasis on moving toward MRI, especially in the high-risk women. Because it's these high-risk women that have this lower sensitivity by mammography. They tend to have denser breasts, and they're at higher risk. So that's why you see this big push to move toward MRI as an adjunctive tool in mammography and screening. And with MRI, the sensitivities are usually in the 90 to 95% range. And there's a lot of criticism about the specificity of MRI, but it's not terrible. It's a 90% specificity. So I don't really think that debunks it as a useful modality. A lot of talk about ultrasound screening sensitivity, especially with the different states coming out with the breast density laws. Tennessee does have a breast density law, as you probably know. And many advocates of those laws have been pushing for screening ultrasound in women. But I'm not sure I can necessarily endorse that when the sensitivity of ultrasound screening is 20 to 30%. And these studies are done with the handheld units. There are automated ultrasound units that are probably going to show a better sensitivity than these have so far. So we may be able to do a little better, but most of the literature basically quotes that you'd have to do an ultrasound screening on 500 women to find one more breast cancer than you did with the mammography and the clinical breast exam. So be careful in making this be better than it is for patients. Yes, we do find breast cancers by ultrasound that we couldn't see on the mammogram, but that's with targeted ultrasound. That's where you know where exactly to look, because either you see something on the mammogram or they felt something, and you go in and you look in that exact spot, and you optimize the parameters of the ultrasound to see it very well. And yes, we do find breast cancers that way very effectively without, with the ultrasound. So yes, ultrasound is a great tool as a diagnostic method, but it is not as helpful as a screening method, okay? A lot of questions anymore about what are the actual guidelines for breast cancer screening, because as you may know, U.S. Preventative Task Force Services came out with a highly controversial set of recommendations for what they thought breast cancer screening should be, contrasting that to what the American Cancer Society and American College of Radiology recommendations are. You can see that there are, some differences. In the ACR and ACS guidelines, we recommend that the patients do their own breast self-examinations every month, once they turn 20 and higher. U.S. Preventive Task Force Services actually said women should not examine their own breasts. They're just driving themselves crazy. But I really personally just have a problem with this, here. I really don't think you can apply that kind of thinking to the way American women are. A lot of the data they used to make this recommendation were from other countries. And, our American women are much more involved in their own care generally. And I can't tell you how many cancers that women have found in themselves that I've seen. So I've seen very few women, maybe 2 in my whole career of 9 years, who really honestly got too anxious examining their own breasts that I told them, you know what, you don't have to examine your breasts. It's okay. It makes you too nervous. Don't do it. We'll help you. We'll examine you, and you don't have to do it. So that's a very rare thing in my experience. So clinical breast exam, and again, we recommend that yearly after age 40. That would be the exam that you do to your patients every year, okay? But, U.S. Preventive Task Force Services said, well, we can't determine the value of that. And I will say this is really dependent on the practitioner. We do get a lot of false positives with these, and a lot of grayness, people sending over some thickening there or this or that. Now, my advice to you with that is if it is hard for you, I know when you feel a thicker place, but thickening is not a mass. And if you can kind of get used to the way breasts feel, you'll realize that a lot of breasts have thicker parts, a lot of breasts feel seedy or beaded in places, and that is the way normal breast tissue feels. So, if you can, you will make yourself a more sensitive and more specific examiner if you can kind of get used to the way normal tissue feels and don't send patients for further evaluation if it's kind of wishy-washy and you're not sure. I mean, if you feel something and it's more discreet and you have a concern about it, of course you should send them for more evaluation. And then, of course, the other major difference that has been, very highly criticized is ACR, ACS recommends yearly mammogram beginning at age 40. Some people will get the baseline mammogram between ages 35 and 40. And then U.S. Preventive Task Force Services says biannual, so every other year mammograms ages 50 to 70. And, this is really hard for us. To exclude these young women from screening is a very hard concept for us to stomach. And it's because I will tell you that about 28% of our breast cancers that we see in our breast center here in our region are in women age 50 and younger, okay? So am I supposed to just ignore them, And if I let a 40-year-old woman sit with a mass in her breast for 10 years before I find it, her level, her stage is going to be much higher. And then I'm going to be able to do a lot less for her. So I really think this is somewhat irresponsible, but you have to realize that they derived this data based only on the analysis of prevention of a death. Okay, they didn't examine morbidity, they didn't examine life years saved, right? And if you were to begin to look at life years saved, then yes, you would not be able to rationalize the exclusion of, the 40 to 50-year-old group in screening, okay? And of course, MRI screening in patients we recommend yearly for high-risk patients, more than 20 to 25% lifetime risk. But U.S. Preventive Task Force Services felt there was insufficient evidence to support use of MRI, and remember that's based on mortality analysis alone. And as I told you, we do know the MRI is more sensitive, but we don't yet have the data to support that it prevents deaths, and that's just because we don't have the data yet, okay? There isn't just enough done yet. Okay, so that's what we recommend for screening. And now I want to just also, if we're using the mammography or MRI or ultrasound, we try to be, very standardized in the way that report that. And I want you to realize that the way things are reported definitely imply the level of risk that we're talking about on the mammogram. So, for example, if I say a woman is a BI-RADS 1 or 2 and she's good for a year for her next mammogram, that means I'm telling you that there's a less than 1% chance of her having cancer, okay? If I say she's a BI-RADS 3, I'll usually recommend a 6-month follow-up. That means she has a less than 2% risk of having breast cancer, okay? That's what that means. If I say she's a BI-RADS 4A and I would biopsy anything over 2%, okay, that's how aggressive we are, then that should say to you, this woman has a 2 to 10% chance of having breast cancer, okay? If it's 4B, she has a 10 to 50% chance of breast cancer. If it's 4C, it's 50 to 95%. If I say she's a BI-RADS 5, it's a greater than 95% chance that that's a breast cancer. It's almost diagnostic of, but we still do get the tissue, okay? And of course, the use of BI-RADS 6 is for those patients that have breast cancer. So remember that there are other standardized reporting systems. There's a liver RADS, there's a lung RADS, those classifications are telling you what the chances are that they have that cancer, okay? And you'll see higher and higher use of these standardized reporting systems in radiology to come. And this should be very helpful for you to be able to tell your patients what it means. That's what that means. And also, when we describe the way the findings are, we are confined to very narrow terminology. We don't say nodule, we don't say spot, we don't say lesion. We can say mass, we can say calcification, and we can say asymmetry. Those are the 3 words that we're supposed to use, okay? And you'll see people using nodule and la. But this is what we are supposed to use. And those also have specific meaning, okay? So asymmetry is divided into categories. And if I tell you that it's just an asymmetry, there's a very low chance of that being anything significant. If it's a focal asymmetry, the risk is 2 to 10%. If it's a developing asymmetry, the risk is 13 to 27%. So if it's a developing asymmetry, the patient needs what? What does she need? Biopsy. Anything over 2% needs a biopsy, right? If it's a focal asymmetry, I will do a workup, and I will try to get what I believe is a risk level of less than 2%, so that I can either say it's normal or that it needs some 6-month follow-up. But usually this requires a mammogram and an ultrasound for us to get that risk level down. If I can't, satisfy myself that the risk is less than 2% or less than 1%, then what does she need? Biopsy. So this is the way we think. We're always thinking of risk levels, we're thinking of percents, and if it's more than 2%, we biopsy. And that's standard care, should be standard care everywhere. Okay, so that's, the skinny on screening. Any questions about that, about the screening so far?
Because we have students, you might want to go over the breast density laws that are proliferating throughout the nation, and what Tennessee says, so they have an understanding. They may not be aware of that as much.
Yeah, so breast density. So for example, we always, one of the things that we will always include in our reports is an assessment of the breast density, okay? And that has to do with, as in this case, how much fat, which is the gray, versus how much of the fibroglandular tissue, which is the white, okay? This patient has greater than 75% of the white in her breast, and so she would be an extremely dense person. So we can rate them from fat, scattered, heterogeneously dense, and extremely dense. Okay, so those are the 4 categories. So this would be the highest one, extremely dense. And in women who have either heterogeneously dense or extremely dense breasts, they have a higher rate of risk of breast cancer than a woman who has a fatty breast have. And that makes sense, right? Because where does cancer start? Does it start in the fat? It starts in the TDLUs, the fibroglandular tissue, the lobules and the ducts, right? So this is where the lobules and the ducts are. So she has a lot more of those, right? She has more places for cancer to start. That makes perfect sense. But if she has only fat in here, I mean, she's really got hardly any place for it to start. That's not to say a fatty-breasted woman can't get a breast cancer, because they can. They really can. So you wonder where, but they can. So in Tennessee, the law is that we must notify them of their breast density. We must tell them, and we're doing that for you. The mammographers are notifying the patients for you. You have dense breasts, and this means that you have a higher risk of breast cancer, and that mammography is not as sensitive for you. Okay? And then we usually will say, if you have, you should talk to your healthcare provider about what some of the other options may be. But we honestly really don't have any other options to offer them aside from what we offer based on their risk level. So if they're more than 20%, we give them the MRI. And the reason for that is at present, there are no risk models, no risk calculators that include breast density, that have validated the effect of breast density on risk. And therefore, we cannot really include that in our calculation of what their risk is. That will come, and then we'll be able to do a little bit more for these ladies. Some of the studies are saying that the dense-breasted woman is even 5 or 7 times more likely to get a breast cancer than a fatty-breasted woman. So some of the rates are quoted very high. I don't think it's probably that high, but there is definitely more cancer in these dense women. It is much harder for us to find their cancers. I mean, can you see a cancer in here? It's really hard, It is. So these are the ones where we're missing. And this woman was 47. And any questions about that? Does that make sense?
And that's not the only state. There are many other states that it's prolific. And
Yes.
Dr. Ransom just came from New Jersey, so these are new laws being put on the books that will affect your patients.
And Tennessee has not said you have to offer them any other kind of screening. They just say you have to notify them.
As New Jersey.
Yeah.
New Jersey does. So
Yeah.
you get the mammogram back that says BI-RADS 2, densely heterogeneous breasts suggest additional studies. You send them for the additional studies, including focused views and ultrasound, and then it comes back BI-RADS 3, recommend short-term follow-up, and then it comes back, now we can follow up with routine screening.
And your impression of that as far as being helpful?
Little to
Exactly, and I would agree with that. It's because I just told you that screening breast ultrasound, you got to screen 500 women to find one more cancer. Okay?
But that's the law.
But that's the law.
That's where it's tipped over from physician autonomy, both in radiology and practitioner, to legislated, mandated treatment.
Depending on where your patient is, sometimes they actually don't find out any of this until they get the lawyer's version of it on a piece of paper with your mammogram was normal, and then you get this whole dissertation in mumbo jumbo. I've had a couple of patients call from North Carolina, especially. Theirs is really very detailed, one huge long page,
Yeah.
and then you're trying to tell them that they're fine.
And this is the problem that when we get lawmakers involved, they don't really understand that, I've told them now that they have this problem, but there's nothing else I can do for them. So what do you want me? Now the patient's all concerned, and I can't give her anything for that. And that's why for years and years, we didn't mention it, because what's the value in mentioning it, aside from getting a person, all worked up. And that's where we are. So anyway, this is a screening case, a person with a dense breast, and these are the 2 standard views that we do. We do a craniocaudal view, which is from head to foot, and then we do an MLO view, which is kind of an oblique sagittal view. We compress the tissue, right? This is what the patients don't like, but we compress the tissue, and that's important to do because it spreads it out so we can see and hear better. And it also decreases motion, makes our resolution better, and so forth and so on. And so in this patient, she was asymptomatic. She does have a high risk. So what would we do else for her besides the screening mammogram normally if her risk is 29%? We just stop here? What else should we do? MRI. So she should also be somebody that should have yearly screening MRI. And, we have had resistance from insurance companies for screening MRI, but if you may know, the Obama administration pretty recently was very explicit in saying that screening MRI and genetic testing are screening tests that will be paid for by insurance companies. So that kind of resistance should go away as long as we're documenting what the risk level is.
Some
I know you are, I know. Yeah, I mean, my the OBGYNs tear my ear off. We're spending all this time, getting pre-certs on MRIs, and I'm like, well, this is the recommendation. This is what we've got to do. We've got to fight them, and I'm not trying to punish anybody, but this is really what the recommendations are and what we do. So this woman had a normal mammogram, and because we think she should be screened, she ended up having a screening MRI. And this is one case where you really could not see this multicentric breast cancer in her mammogram. I mean, I'll go back. This is the right breast. I mean, do you see it? I don't, you could say, I don't know, is that something? I don't know. Maybe. So you can see how MRI kind of brings, with the enhancement, we give contrast with these, how it really brings out these abnormal areas to our attention. So in the MRI, with mammography, we talk about masses, asymmetries, and calcifications. In the MRI, we talk about masses and something called non-mass enhancement, which is kind of like what a calcification or asymmetry might have been with a mammogram. So this is a mass, right? It's round, it's got borders that we can characterize. Some of this in here, though, is clumped non-mass enhancement. So we're expecting, and this is even what we call clustered ring non-mass enhancement. So we've got all these different terms, which again will predict the likelihood of this being cancer. Usually non-mass enhancement in MRI is going to be DCIS or atypia or something like that. And a mass, again, masses always mean invasive cancer, almost always. Yes, DCIS can occasionally present as a mass, but that's not usual. So this would be, we would be thinking that this stuff here is probably DCIS, this is probably invasive cancer, that's probably invasive cancer, and this stuff would be, again, DCIS. But the bottom line is she's got all this disease, probably fairly diffusely involving that quadrant. It's spread out over 5 centimeters. This is multicentric disease, and the treatment for multicentric disease is generally mastectomy. Okay, and in this 47-year-old, should you consider doing a mastectomy on the other side? There's no cancer here on the left. What do you think?
Consider.
I think you should consider it. And the reason is cancer recurs. She's 47. She's going to be with us another 40 years. She's going to get cancer again. Now, you can have mastectomies and get cancer still, but it's 90% reduction, okay? All right, that's just showing you the... All right, this is what a more normal screening breast MRI might look like. And you can see some of the problems with MRI where it's hard is, there's always these little dipsels of enhancement, okay? These we call foci, or we call it stippled non-mass enhancement. Stippled non-mass enhancement has a benign connotation. So it can get, and this, you see where this outer breast tissue sometimes enhances more. That's still considered a benign pattern, but boy, it gets a little harder to distinguish, and that's why we get a lot of false positives sometimes with MRIs. It does get very difficult. You need to get the highest resolution you can. It gets tricky to distinguish, especially with the non-mass enhancement. And the other problem with non-mass enhancement, which again implies DCIS, is that some DCIS really doesn't enhance very much, and so we cannot see all DCIS with MRI. So especially the lower grade DCIS. Okay, so here's another case. This is a 39-year-old woman. She was asymptomatic, but we ended up finding a triple negative breast cancer in her. Anybody see her cancer? Who thinks it's on the right? Who thinks it's on the left? Raise your hand if you think it's right. Raise your hand if you think it's left. Okay, so you're right. So where do you think it is? Do you think it's that? Who thinks it's that? Raise your hand. So this was not her breast cancer. This was her lucky cyst that we worked up because we saw it. And we worked it up and we found her breast cancer right next to it. In here was actually her breast cancer. If you see, maybe it's just a little distorted right there. It's maybe sort of spiculated right there. So she had this incidental cyst that probably saved her life, caused us to do a workup. I mean, maybe we would have seen this, but maybe not. And so then that's her cyst, that's the cancer. And so then, you know, she went on to treatment, but it was triple negative, and we'll talk about what that means a little bit later. So here's another kind of tricky case. So she's 45, she has family history, her lifetime risk is 30%. In 2010, she had this, right? It's asymmetric. It's a focal asymmetry even, right? Focal asymmetries, you know, 2 to 10% risk of breast cancer. So that's 2010, and this is 2012. 2010, 2012. You see any change? No, I don't either. But I don't like it because it's a focal asymmetry and it's just sitting there. And it was biopsied and it was DCIS. So DCIS can sit around there for years and years and years because it can be low grade. And then one day it will decide to, and it will explode, it will become invasive, and it will get in her lymph nodes, especially when she's 40-something. So DCIS in her, even if it's low grade, will eventually do something harmful to her. But obviously, it wasn't doing anything harmful to her from here, from 2010 to 2012. And it probably could have sat there even longer. And that's the hard thing, is that, you know, DCIS could sit in there a while and not cause anybody any harm. But one day it will. Okay, and this was that same patient, and this is her preoperative MRI. So again, this is what non-mass enhancement looks like. It's clumped enhancement, you know, even maybe some little dendritic branching. It follows along a duct, you know, so it's a ductal distribution. Those are kind of things that suggest to us that this is the bad kind of non-mass enhancement, and that it has a high chance of being DCIS, which of course it was. Okay, here's another case. She's 57. And anybody see anything? Anybody see anything on the right? You see something on the right? How about the left? Left? You think right or left? Right. Yeah. So maybe something there, huh? Let's see. I don't know if I even remember this case. Yeah. Okay. Even in the middle, huh? So we did this. We found this little area, and I think it's just not projecting very well. We found what looked just a little bit distorted, like a little asymmetry there. So if we don't know for sure that it's a mass, we'll still call it a focal asymmetry, and then we'll do additional workup. And it may change from a focal asymmetry to a mass later on when we get more information. And this was this same woman, her breast MRI. And again, you know, we really have underestimated how much disease that we can see on the mammogram in her breast. And this is, you know, this is a preoperative MRI, so this isn't a screening MRI anymore, but this is another important use of MRI, which is in a patient that we know has breast cancer. Maybe her, you know, breasts are very dense, and we have a concern that we might not be seeing everything. A lot of the surgeons will like to do a preoperative MRI just to see what the extent is, because that just went from a lumpectomy candidate to a mastectomy candidate right there. So that's why you need to know beforehand. Okay, so, you know, I've talked about, you know, what multicentric might mean. You know, it might mean you need a mastectomy, but some other things may play into it, and there's a lot of the important thing to know about breast cancer is how we're going to stage it. Now, just being multicentric doesn't necessarily mean it's going to be higher stage. I mean, it usually will be a little higher, but it doesn't mean it's going to be a stage 4 necessarily. And the stages, of course, of any kind of cancer are because of how the survivability is going to be by stage. And of course, the higher stage, the lower survivability. Stage 0 for breast cancer is the DCIS, LCIS, or Paget's disease isolated to the nipple. And those, even though it's stage 0 cancer, there still is treatment for DCIS that is, you know, almost like breast cancer treatment. The only difference is they might not do an axillary lymph node dissection. But they will treat it with sometimes even chemotherapy. And of course, stage 1 or 2 is where we're trying to find the cancers, especially stage 1. If we can find a patient in stage 1, we know that they're going to survive their breast cancer. And those patients are also much more likely to be able to have a lumpectomy and you know, have a much better outcome, much easier kind of course of treatment for them. And then, you know, Of course, stage 4 is by the time you have distant metastases, and honestly, it's pretty rare anymore that we're finding cancer that late. And this is kind of the survivability by stage. Overall, you can see that the survivability of breast cancer is very high, 89%. So we're finding these breast cancers early, and we are able to make a difference and save them, as long as we can find them early. But even stage 4 patients often can do pretty well for quite a while with chemotherapy, and they can still survive for a number of years. And the recurrence, so you need to remember, though, that there is a recurrence rate, okay? Even if we, give chemotherapy, we give radiation therapy, which radiation is a good adjunct to lumpectomy, where you can really, get results that are just as good as mastectomy with a lumpectomy and radiation. And some studies are even saying that it's even better than a mastectomy for recurrence. But even with those things, we do see recurrence. So for stage 1, we see a 7% recurrence at 5 years, stage 2, 11% at 5 years, and stage 3, 13% at 5 years. And, at 10 years, there's a 20% recurrence of breast cancer. So that's why in that 47-year-old, we're saying, you want to push more toward probably mastectomy, because you could do her lumpectomy now, but in 10 years, she's got a pretty high chance. If you tell her in 10 years, you have a 20% chance of getting breast cancer again, guess what she's going to want? Not a lumpectomy, I can tell you that much. And of course, the radiation makes quite an impact. Here's an example of a stage 1A cancer. Just a little mass. You see it maybe a little something was in there. Very little change in 2 years. It's probably a low-grade mass growing very slowly. But that's something that we're going to be able to fix. Oops. And this was the additional workup. So if we see a mass, of course, we're going to do some spot views of it. Usually spot magnification views to help us see the margins. Remember, round is bad. Spiculated margins are bad. And so that's going to prompt an ultrasound. And in the ultrasound, the characteristics of this mass that make it suspicious are these angular margins, again, that it's round, or even maybe a little bit perpendicular rather to the skin surface. Some of them will shadow behind, some of them have flow inside, and there's a lot of good evidence coming out with the firmness of a lesion, where we use elastography to compress. And firmer lesions are another independent predictive factor for it being breast cancer. So let me see what this one was. I might skip ahead a little bit just because of time. I'll show you this case. So this was a stage 3A case in a 49-year-old. And I'm showing you this case mainly because of the distortion is another thing we look at, and the distortion is another very helpful thing. And almost always, if there is true distortion present, then that should be something that's biopsied, because again, that has a fairly high predictive rate of it being cancer. And this patient, even though we couldn't see it, she ended up having a pretty juicy lymph node in her underarm. With these, what we'll usually do, if we identify a node in the axilla when we're working up the mass, the surgeons will usually ask us to go ahead and do a biopsy of both the mass and the lymph node. And that's because if they confirm that this is metastatic cancer, they will then do not a sentinel axillary lymph node biopsy, but an open lymph node biopsy, which is, again, not as nice for the patient, but because of the higher risk, they need to do more. And lymph nodes are a little tricky. Lymph nodes under the arm can be pretty big normally, because it's just a dirty area. But we look a lot at the morphology rather than the size of the lymph nodes. This lymph node does not have really a fatty hilum anymore like a lymph node should. This cortex is very thick. It's nodular looking. So those are kind of the things that we look at more to predict an axillary lymph node to be, a possible metastatic lymph node. This is that same one. So, as you can see, there are different stages of breast cancer, but there are also different grades of breast cancer. There are different molecular subtypes of breast cancer. And that is why not just the stage determines, how a patient's going to do, but also the type of cancer determines how a patient's going to do. Some breast cancers really are lambs. You find them, they're small, they have a lumpectomy, they do great. They never have a problem again. Some breast cancers are bears. They're have an unfavorable molecular subtype. They're highly likely to recur. They're less responsive to treatment. They're usually found at a more advanced stage, and often in younger women. And those are the ones that you really got to intervene on and be more aggressive with. So again, we consider not just the stage of breast cancer, we consider the grade, we consider the hormone receptor status as far as estrogen receptors and progesterone receptors. We consider whether there's the HER2 new gene amplified in the mass. And there are also a lot of literature looking at the actual molecular subtype. So these are some of the molecular subtypes, the luminal A, which is usually a lower grade with ER positive, and then there's luminal BC, higher grade, and they are also still ER positive, but they have they're more aggressive. There's what they call normal breast-like, and they're not sure how that contributes to survivability. And then there's the basal kind, which is one of the most aggressive types of breast cancer. These are often the triple negative breast cancers. These are often seen in patients with the BRCA gene or in young patients. And it comprises 15% of breast cancer. But the survivability is only 77% at 5 years, as opposed to the 89% overall we see for others. And the recurrence rates of these are much higher. So those recurrence rates I quoted you are higher for these type of things. And when they know that it's an unfavorable subtype, not all patients get chemotherapy for breast cancer, but when they know that it's an unfavorable subtype and they're likely to recur, they will definitely give chemotherapy to the patients, not just tamoxifen, but the full chemotherapy. And these are just curves that show you the survivability based on the subtype. You can see quite a difference, between the different types and how the patients are going to do. And again, this is information that helps us tailor our patient care, patient-centered care, precision medicine, directed at that patient's specific disease and her specific risk level. A lot of the oncologists are using something called an Oncotype, you may have seen. So it looks at the different genes in the tumor, right, the different genes inside the tumor, and it will predict the likelihood of recurrence. And if they use it on DCIS, it helps them determine if radiation is needed or not. And they're using it to determine only really right now for the stage 1 to 2 breast cancers, the lower stage breast cancers, that whether or not they need to give those patients chemotherapy. And some patients really are not getting chemotherapy for their low stage breast cancers with a favorable subtype, which is great for them. Because, you guys know that the chemotherapy for breast cancer patients, their hair always falls out, right? It's if you've seen a patient on chemotherapy, it's not an easy thing to go through. The radiation is much better tolerated, and if we can avoid that and we don't need to give that kind of big gun treatment, then it's much better for the patients. Okay. So I don't know. So here's an example of a lamb type of breast cancer. She's 53. It's just this little thing. She's going to get a lumpectomy. She's going to do great. It would be nicer if she was 70. Then we really wouldn't worry about recurrence. But, she's going to do great, and they probably would just do a lumpectomy for something like that. And these lymph nodes in her axilla are more the kind that we see. This is a pretty long lymph node. If you measured it, it would be kind of long. You would want to think that it's enlarged. But see how thin the cortex is and how much fat is in the hilum. That's a benign morphology, and even though the lymph node's long, it's considered a benign lymph node. And that particular cancer was also ER/PR positive. So they would probably, maybe not even give chemotherapy for this, but they would probably put her on tamoxifen after. Now this is a 40-year-old woman. This woman's got 2 kids, and we see this asymmetric tissue compared to this side. So this is a much harder thing to deal with. This was a HER2 amplified cancer, and there's a subtype that was harder to treat with chemotherapy. Now they've come out with new treatment regimens that are doing a lot better now with the HER2 amplified, but it does imply that this is a more aggressive cancer and one that's higher likelihood of recurrence. And this is a lady who had triple negative cancer. And this is her MRI, and you can see how extensive it is. She has this big old node in there. And this patient, was young. This is really the shark of breast cancers. And these are the kind of women that we really need to find it before it occurs. We need to prevent it from happening before it happens, if we can, by doing genetic testing, by screening her earlier with MRI. And if she's got a very high risk, either giving chemopreventative medications or considering those more invasive surgical preventative interventions. So that's basically what I wanted to talk about today, just to get you to understand that this disease is heterogeneous. And if you get people talking about we're over-diagnosing breast cancer, we're over-treating breast cancer, then I think you have to put it in perspective. We may be over-diagnosing in 70-year-olds DCIS, okay? If you're 70, I don't almost want to see your mammogram because I don't want to find DCIS in you. Or if you're 90, I don't want to put you through having to have go through all that. Because if she's got DCIS in her breast and she's 80, she's more likely to die of something else, okay? Way more likely. So, and this is a good argument for why maybe we can just continue screening in some of our women of advanced age. Right now, U.S. Preventive Task Force Services says 70, you stop. We're saying more like, well, when you know the patient's life expectancy is less than 5 or 7 years, or if they have a lot of other comorbidities, then you should stop. Send in 90-year-olds for mammograms. I'm not really sure what we're doing for them. So I would, I would advocate, being a little gentler with the older ladies. And it's in many cases better not to see it, better not to find it, because they'll survive that breast cancer, but they won't survive their coronary artery disease or whatever else they got going on, okay? So, but in a young patient, let's pull out all our guns. Let's do everything for them we can, because those are the ones that get the bad cancers often. Those are the ones that we can save many more life years, years of their productivity in society, taxpayer money, however you want to look at it. Those are people that we need to help. Any questions?
You've really talked to it, but you haven't divided it. Could you talk to us about premenopausal breast cancer versus postmenopausal breast cancer? Because when we talk about the effect of estrogen and the lack of it, there seems to be a difference in the veracity of it, the ability to make a difference in their life. As I've told students in the past, my grandmother went for her mammogram at 85, was found to have DCIS, went through a surgical procedure, and died at 93 from something entirely different. So, could you give your viewpoint of that?
Yeah, I mean, I that's kind of putting the point on it, that, in that case, we probably made no difference in her life expectancy whatsoever. We could have just left that DCIS alone, most likely, and it never would have done anything to her before she died at 93. So we haven't, because I think what the age of menopause is so variable among women, we haven't divided up as far as premenopausal, postmenopausal. We're looking more at age groups now. With the breast cancer, but you're right, when you're getting into the 50 plus, you're basically talking about postmenopausal patients. And our risk assessment tools do incorporate whether they're premenopausal or postmenopausal in them, or the good ones do. So that will, if they're postmenopausal, their risk does go down in those risk models. So even if they you'd be surprised, they may have their mother had breast cancer, but once they're past a certain age, their risk level almost becomes normalized. So you may think they're high risk, but they're not, because they're 60 and they've had their children fairly young, and they're not obese, and they don't really have any other risk factors. So you really do have to look at all the factors, and certainly their menopause, their menstrual status is one of those things. We use a tool right now that's called a Tyrer-Cusick risk assessment tool, And we like that one because it does incorporate that, and it incorporates the weight, the patient's weight. We like it for that. It gives a pedigree. We can talk about the father's side of the family with that tool. So for now, I think that is the most accurate tool, and it does help us to include all of those things in it. And it does really, it overweighs, it definitely puts a much greater risk level to the younger women, and it really, you'll see the risk tapering off in the older women pretty quickly, even with a family history.
And a follow-up to that, since they are using weight gain, has literature from your all standpoint documented a amount of weight gain in the postmenopausal period that would tip over the scale for them to be more at risk for a postmenopausal breast cancer? I've seen 25 pounds weight gain after menopause as being a possible risk factor.
Yeah, honestly, I don't know the literature on that. Right now we're looking at just absolute weight, not change in weight. And that tool, it only looks at absolute weight, not weight change. So yeah, I don't know what the effect, there may be literature and I'm just not familiar with it, what the effect is of a certain amount of weight change postmenopausal. Yeah.
Question: what do you think about tomosynthesis? We've been seeing ads for that.
Yeah, tomosynthesis is, again, it's a new technology, so that we don't have, it's not data rich yet. So I do think that it's mainly going to help us probably improve sensitivity of mammography a little bit, and also decrease the callback rate, okay? Because we'll be able to characterize the margins of masses a little bit better. If you see a mass to be circumscribed, it's not going to be breast cancer. So I think you can have a lot more that don't go into follow-up and that are just considered benign, and then go on to their yearly screening. You avoid those 6-month follow-ups as much as possible, and that will help with that. It may, we don't have enough data yet to say for sure, it may also increase our sensitivity. It basically, kind of like a CT, it leaks through slices in a patient. It's the same sort of thing. You have slices through the breast, so that's why with a standard mammogram, the tissue is all compressed together. And with the tomosynthesis, you're actually seeing through the different layers of the breast, so you don't get the overlap of shadows that can make things look like something if they overlap a certain way quite as much. But again, we are demoing tomosynthesis at our breast center here locally this fall, and it's something that we're going to be having eventually. Most places are moving toward breast tomosynthesis, but like I say, the initial research is positive for it, but probably is not substantiated enough yet.
So you don't adopt it? You haven't adopted it?
Yeah, but I do support it. I think there's very good promise for it, and the more it gets used, the more data we'll have to show it. And we'll be using it here eventually. Yeah. And just so you know, the tomosynthesis, the dose is the same as for a standard mammogram, but most people are still doing the tomosynthesis and the standard mammogram. So and they're doing the tomosynthesis only on the certain higher risk subset of patients, or the dense breasted women. That's another thing we can do for dense breasted women. So they're going to get a double dose because they're going to get both. But if you just did the tomosynthesis alone, it would be just the same as a mammogram, or about the same. Yeah. Any other questions?
Thank you very much. Please fill out your evaluations and turn them in. It does help us in regards to CME.